Good morning. Thank you for joining us this morning. My name is Paula Schneider, and I serve as the leadership chairperson for the Dystonia Medical Research Foundation. And importantly, for today's meeting, I am proud to say that I live in Connecticut. It is my great pleasure to welcome you this morning. We have been trying for some time to get a Connecticut State meeting going, and now, because of the ease of Zoom, we are actually doing it. This program is being presented as a webinar. This is a little different than a Zoom meeting that some of you may be familiar with, and we are recording it so it can be viewed later on. Only our speakers will be able to be heard today. Everyone else is muted to keep the background noise to a minimum, but we want your questions. Please use the chat or the questions tab at the bottom of your screen and submit your questions as you think of them. We will do our best to get to all of them today. I am pleased to be joined today by Janet Heidstetter, Executive Director of the Dystonia Medical Research Foundation, and Janet will moderate the questions for us today. We have time dedicated for your questions, so feel free to ask away. At this time, I am turning the program over to Janet, and I'll see you later.
Thanks, Paula. Good morning, everyone. Thank you for sharing your Saturday morning with us. This is our agenda for today. If we were meeting in person, we would have had a copy for you, but want you to see what we have planned for this morning. We'll hear an overview of dystonia, and we'll learn about the current treatments. And then following that presentation, we'll hear about the benefits of physical therapy for dystonia. And then our experts are going to receive your questions. So following that, we'll have a quick overview of the programs the DMRF has to offer with a focus on support and advocacy. And then we'll wrap it up. So without any further delay, it's my pleasure to introduce our speakers this morning. Dr. Duarte Machado is the Director of Program Excellence and Recognition, the David and Rhoda Chase Family Movement Disorder Center with Hartford Healthcare, where he has developed a multidisciplinary innovative care model for dystonia. Dr. Machado received his medical degree from the University of Connecticut School of Medicine. He did his internship, his residency, and his fellowship at Yale University School of Medicine. Dr. Machado has been a longtime friend to the DMRF, speaking at many previous foundation educational programs. He is dedicated to exemplary patient care, and we're very pleased that he could be with us this morning. Following Dr. Machado's presentation, we will look forward to hearing from Megan Rood. Megan Rood is a physical therapist at Hartford Healthcare Rehabilitation Network in Vernon, Connecticut. She has been working in outpatient neurology-based clinics since graduating in 2005 from Northeastern University. She is certified in several special programs for Parkinson's disease that have provided her with additional education and insights in the management of other movement disorders. She is a certified stroke rehabilitation specialist and a certified brain injury specialist, which have both allowed her better understanding of different neurological diagnoses. We're looking forward to both of these wonderful presentations and to a great morning. I'll turn the program over at this point to Dr. Machado. Dr. Machado?
Okay, so thank you so much, Janet, for that lovely introduction, and for everyone for joining us this morning and for taking time out of your day to hear more about the DMRF and dystonia. So I'll be reviewing dystonia and providing an overview and treatment as well. So the objectives, again, to start with an overview of the physiology of dystonia and focusing on three key areas: the loss of inhibition and excess of movement, resulting in dystonia, the sensory abnormalities that can occur, and then the maladaptive plasticity that can result in dystonia being long-term. The diagnosis, so how it's classified and the causes, and then review some treatments, including botulinum toxin injections, oral medications, and deep brain stimulation. So dystonia is defined as a syndrome of sustained muscle contractions that frequently cause twisting and repetitive movements or abnormal postures. And it's a common movement disorder. So in our center and centers around the world, dystonia is the third most common movement disorder behind only Parkinson's and essential tremor. So we'll start with the first part, and that's reviewing the physiology of where dystonia comes from. So in looking at these diagrams, if we were to evaluate the place where dystonia occurs, that is the basal ganglia. The basal ganglia is a structure deep within the brain. Now, if we were to take a brain slice in this orientation, a caudal view, we see that the basal ganglia consists of several structures, the globus pallidus, the putamen, shown in light blue, and then the caudate shown in brown. So these structures together form the basal ganglia. Now the basal ganglia works by receiving inputs from the cortex. So in that same view, the cortex is located on the outer part, the cells on the outer part of the brain. They send projections to the basal ganglia. And so a motor command that starts in the cortex is then amplified in the basal ganglia and sent back to the cortex. And it's done so via one of two pathways. There's a direct pathway shown as D1, and it's called direct because there are less connections, cell-to-cell connections for the signal to travel through before it goes back to the cortex. So the D1 is a direct pathway, and it helps to bring out the desired movement, so facilitate the movement. While the indirect pathway, containing a different type of dopamine receptor called D2, it inhibits unwanted movement. So this way, one can really execute a movement in a very precise fashion, not going too far. For example, to pick up a pen, you don't want your limb to go too far and go beyond the pen, nor do you want it to be too short of a movement where you haven't reached out far enough to grab it. So it has to be a very precise movement. And again, that's coordinated via the D1 and D2 pathways. And dopamine as a neurochemical controls whether the signal is increased or decreased, because dopamine is that neurochemical shown in those dark circles at the top that bind to and activate either the D1 or D2 pathways. So we know that the basal ganglia is involved in dystonia based on several lines of evidence. So for example, we know that normal dopamine signaling is vital to basal gangliar function. And since dystonia is associated with abnormalities in dopamine, this suggests an important link between basal ganglia and dystonia. Many dystonic patients experience alleviation of symptoms after deep brain stimulation, for example, and deep brain stimulation involves placement of an electrode into the basal ganglia and then damage to the basal ganglia. So this could be due to a variety of causes. So structural lesions, vascular injury like stroke, or other neurodegenerative processes that affect the basal ganglia, like Huntington's disease or Parkinson's disease, can lead to what's called a secondary dystonia. So not primary dystonia, not a dystonia due to processes whereby the dystonia is a primary neurological issue, but secondary, so whereby there's some other process like stroke or Parkinson's that cause damage in the basal ganglia, and that's why it's called secondary. It's secondary to something else. There are three general abnormalities that appear to underlie the pathophysiology of dystonia, and I'll review each of these three in more detail. So loss of inhibition and excess of movement, sensory abnormalities, and maladaptive plasticity. So the first one, loss of inhibition and excess of movement. So when we want to execute a voluntary movement, the brain has to suppress other possible movements. So that's called surround inhibition. So in this way, the motor cortex can produce a very accurate movement, like what I described in reaching out for a pen, for example. The lack of inhibition may be responsible for an excess of movement and the overflow phenomenon that's seen in dystonia. And this imbalance occurs via two ways. So one is that in dystonia, there's an excess of signal to the thalamus and then to the cortex. So this leads to involuntary and continual activation of regions of the cortex that's shown in these larger arrows. So too much output from the basal ganglia causing dystonia. So that was back to the cortex, but there's also another signal, another pathway down from the basal ganglia to the brainstem and then to the spinal cord, shown in this larger blue arrow pointing down, down into the brainstem and spinal cord again. And this leads to an involuntary and continual activation of a structure in the midbrain called the neural integrator. So there's excess signal out of the basal ganglia, both up to the cortex and then down to the brainstem. But there are other regions of the brain, including the cerebellum, that also play an essential role in dystonia. So what I showed was a simplified diagram of the networks out of the basal ganglia, but as with most things of the brain, it's much more complex than that because the brain integrates so many other issues. So for example, from the visual cortex, that input, the proprioceptive receptors in the neck, the cerebellum. The cerebellum is the region of the brain whereby that helps also with coordination of movement. That provides signals to the neural integrator brainstem and thus to the globus pallidus. There are some patients, for example, that have a dystonic tremor, and that dystonic tremor involves then dysfunction of not only the basal ganglia but the cerebellum, because tremor disorders arise from loss of a certain cell type called the Purkinje cell located in the cerebellum, and the cerebellum is located in the back of the brain. So all of these neural networks are involved in sending signals to other parts of the brain, and so it becomes very complex when piecing this together of how one portion of the pathway, if there's dysfunction there, that can affect other parts, and also helps to explain why there's so much heterogeneity or variability in dystonia from one patient to the next, whereby one patient may have a greater degree of dystonia or greater manifestation of dystonic symptoms, like for example, the addition of tremor compared to other patients with dystonia. Now let's discuss the sensory abnormalities of dystonia. So we know that there are sensory findings in patients with dystonia, such as pain, with pain being such a major factor for many patients. So sensory inputs modulate the dystonic symptoms, and a well-recognized clinical sign of dystonia, in particular cervical dystonia, is the sensory trick, whereby symptoms may improve by touching the cheek, for example, as a common sensory trick. So this can be referred to as a geste antagoniste, whereby the dystonia is improved by applying a certain pressure, touching the chin. Some people hold an object between their teeth if they have a mege, a type of dystonia involving the jaw muscles. So I saw a patient recently that he puts a piece of cork in between his teeth, and that helps to really relax his jaw. And that's helpful. Even sometimes like something small, like even a toothpick between his teeth is enough for this particular patient to be able to relax his jaw enough to speak more clearly. Other patients, I have some patients with fairly significant dystonia of the neck that when they're in the car, they just have to put their head back slightly and apply a bit of pressure to the back of the head, and that allows them to really maintain good control of their neck muscles. There's also task specificity, so whereby there's selective activation of involuntary movements by specific tasks. So this is a very common reason why people have task-specific dystonias. So writer's cramp, playing a musical instrument of various types, so a musician's dystonia. And then there's also state function. So this is whereby variation in severity of dystonia with specific action can occur. So patients who have a lower limb dystonia may walk backwards better than walking forwards. There may be patients who have dystonia when speaking but not eating. So this particular patient I was referring to, a lot of jaw dystonia when he tries to speak, but he does not need to do much of any type of modification when he's eating, for example. The dystonia doesn't bother him then. So the basal ganglia plays a role in sensory gating, and this is filtering out the sensory information of what's passed to the motor system. And studies have shown that in patients with task-specific dystonia, there's a sometimes dramatic disorganization of, for example, the normal finger representations of both hands on the primary sensory cortex. So this shows a sample of that in a control patient, a patient without dystonia, when they move the hand, for example, the digit number 5 and digit number 1, shown in the yellow and red, it maps to a specific part of the sensory cortex. So the sensory cortex is located in the parietal lobe, and the parietal lobe sits right behind the frontal lobe, and it's separated from the frontal lobe by what's called the central sulcus. So the central sulcus just means a groove in the surface of the brain, and it's a deeper groove that divides, again, the frontal cortex and the parietal cortex right behind that. And we can see that the digits, the two fingers, are mapped to the sensory cortex located behind the central sulcus in this diagram. So the front is anterior, the back of the brain is posterior. And someone with dystonia, however, the two digits are close together and overlap a little bit. And so there's not that separation in the brain to allow for a particular person with dystonia to be able to use the fifth and first digit separately at times, that when they try to use a first digit, that fifth digit may move also involuntarily because those two brain regions are too close together, abnormally so. And so when the person tries to activate one digit, the other one moves along with it. And so this is the type of abnormalities that have been described in some patients with dystonia. The third thing is called maladaptive plasticity. So neuroplasticity as a concept refers to changes in neural pathways and synapses, which are due to changes in behavior, environment, neural processes, thinking, emotions, as well as changes resulting from brain injury. So we know our brains can adapt, and that can occur on a variety of levels. So it can occur at the cellular level or a larger scale. So this has been well described, in particular in brain injured patients, whereby they are trained to activate brain regions that have not been injured in order to compensate and do the tasks of those areas of the brain that have been injured. And so our brain can certainly remain plastic to a certain degree into adulthood and experience changes of brain's physical structure and functional organization even. So while it may not be as easy to pick up a musical instrument, for example, as an adult compared to as a child, it certainly is still possible. And with training, it's strengthening those neural pathways that are involved in a certain task. And that is an example of brain plasticity. So when we think about dystonia, such as, for example, hand dystonia, this is typically triggered by a period of intense training of a particular movement. So overtraining may induce a change in connectivity between the sensory motor cortices, between the frontal and parietal lobes, for example. And this leads to an inappropriate association between sensory input and motor outputs, which in turn cause errors in selecting the muscles used in the voluntary movement. So it's unknown why some patients develop dystonia after excessive training, whereas others do not. There's certainly a lot of great work further investigating potentially some genetic associations and predispositions in this case, but more research needs to be done. At the cellular level, it's thought that the activation in doing that task leads to an excessive synchrony of neurons in the brain. The neurons, this is just a schematic shown in blue here, there's millions of these, and they're interconnected with one another and then interconnect with other brain regions. So if the neurons start to connect and send signals with neighboring neurons that typically they wouldn't connect with, then that leads to a problem that could be permanent. And this maladaptive synchrony of cells, whereby they start to communicate with one another when they shouldn't, then might lead to a dystonic movement. And that's where deep brain stimulation is thought to be helpful to help break the synchrony that is existing between cell regions. So deep brain stimulation alleviates dystonic symptoms by desynchronizing the activity of cells, for example, in the globus pallidus, thus restoring the normal plasticity within this sensory motor loop. Because plasticity is a process that evolves over time, unlike other movement disorders like essential tremor and Parkinson's, where once we turn on the deep brain stimulator, we can see the effect right away, DBS or dystonia is different, and it can take several months before clinical benefit is seen. So this process of a progressive plasticity and neural reorganization is thought to be what accompanies the long-term effect of DBS. So in other words, the bad motor memories that have already been learned take time to unlearn. So what I reviewed is that there's this combination of abnormal inhibition and plasticity with environmental influences such as repetitive activity that can result in dystonia, and that the contribution of abnormal plasticity and use dependence may determine the specific clinical profile of individual patients. The abnormal plasticity plays a stronger role in patients with generalized early onset dystonia, and then a weaker role in those with focal hand dystonia, where additional factors like repetitive hand use, trauma are needed to trigger and then maintain the dystonia. So when we think about the spectrum of dystonia, then we look at the cause, so genetic cause, and I'll review that in more detail shortly. Potentially for susceptibility genes, the environmental factors that I've mentioned, the circuitry involved, so basal ganglia, the direct, indirect pathways, other structures of the brain like the cerebellum being involved, and then the functional consequences of that, the abnormal sensory motor cortex plasticity, so that interplay between those two parts of the brain, the sensory cortex and parietal lobe, motor cortex and frontal lobe, and how they can change, the decreased inhibition to the cortex, brainstem, and spinal cord, leading to excess movement, thus resulting in the agonistic and antagonistic co-contracture of muscles and overflow movement, and leading to the various types of dystonia we see clinically. At the top, we see that younger patients tend to have problems in this column, in the first column, older patients in the latter column. So when we see genetic dystonias and those involving abnormalities in the sensory motor pathways, those tend to be the younger patients, and older patients, those tend to be due to, for example, the other non-genetic causes, and then involving the pathways between cortex and brainstem. But certainly there's interplay, as we can see from the arrows back and forth, there's interplay between all of these ideas. So now coming to discussing diagnosis, I've certainly heard of patients who can go for some time without having the actual diagnosis of dystonia, where they may be told that there's something else. So when it comes down to the diagnosis of dystonia, patients ask, do I have dystonia or disorder mimicking dystonia? Is the dystonia present in isolation, or is it in the company of other movement disorders, as I've described already, like Parkinson's or Huntington's? Or is it a symptom of an underlying other pathologic process? What workup should be done, and then treatment. So dystonia differs from the 4 other hyperkinetic movement disorders. Um, the other common ones include myoclonus. So myoclonus is quicker than dystonia. It's not a sustained movement and doesn't produce posturing. Chorea is a random, unsustained movement without posturing also. That's a more of like a dance-like motion. Tremor is regular, rhythmic, and also not sustained. And tics are a voluntary movement, and they're usually an urge movement. So patients describe an urge to produce the movement before it occurs. That one can be quick or slow, postured or not. So tics might be difficult to distinguish from dystonia, and sometimes it does require the expertise of a movement disorder specialist to really make the diagnosis, because of the fact that patients can have more than one movement disorder, where dystonia may not be seen in isolation, but be seen with one of these others. When we classify dystonia, then we classify it based on whether it's a genetic dystonia, whether there's dystonia plus syndrome, like dystonia plus some other movement disorder, as I described, whether it's a secondary dystonia due to some external factor, like a drug, for example. There are certain medications that block dopamine, and I mentioned dopamine is critical for the basal ganglia pathways to work properly. And if a person takes a medication that blocks dopamine, such as an antipsychotic or a medication for nausea, such as metoclopramide, that can cause a secondary dystonia due to blocking dopamine. And then there are also hereditary degenerative dystonias that occur in conjunction with some other inherited neurological condition that's generalized. Now, this is from the DMRF, and it shows that dystonia can really be present in so many different parts of the body, really head to toe, as shown here, with common forms being cervical dystonia. And cervical dystonia is the most common adult onset type of dystonia. We could see common misdiagnoses that patients are told, oh, it's a cervical disc disease, osteoarthritis, muscle strain. Patients may see an orthopedic or physiatrist prior to then being seen by a neurologist. Similar with other issues, blepharospasm can be confused with myasthenia. Spasmodic dysphonia can be confused with some other laryngeal or voice disorder, and patients may be seen by an ear, nose, and throat before the neurologist as well. So a variety of different types of dystonia presenting really head to toe. Now, what's causing the dystonia? When we see a patient with dystonia, we have to ask, what is the etiology or cause? What's the symptom onset? Because a person who's younger, certainly that clues us in that it might be a genetic form compared to later onset. And then the body distribution. Where is the dystonia present? Here's a spectrograph showing the typical age of onset for some common forms of dystonia. When we see a child, then with a generalized dystonia, certainly we have to do genetic workup to evaluate that person for a type of dystonia called DYT1. Writer's cramp is common in younger individuals. Cervical dystonia, common age of onset in the 40s. then spasmodic dysphonia also, and blepharospasm that tends to come later. So if we see a person who has some eye blinking, then and that person's younger, then it's unlikely to be blepharospasm, for example. I saw a patient in my clinic with asymmetric eye blinking, and that person likely has what's called hemifacial spasm, which is a type of myoclonus and not blepharospasm because she was in her 30s. So certainly age of onset can also be helpful to determine the type of dystonia someone has. Most dystonias begin as focal dystonia, except those of childhood that can be generalized. And again, I mentioned that the range of onset for dystonias is small, that it's unusual, again, to see a blepharospasm in someone who's in their 30s. Then we look at distribution. So is it focal dystonia, or is it beyond just one part of the body, in which case we classify it as segmental, hemidystonia, where it involves one side of the body, or generalized dystonia involving the whole body. These are classification of some of the genetic dystonias. The most common ones are DYT1, DYT5, and DYT11. Then there's also category DYT7 of familial torticollis, which is 12% of up to 12% of those with cervical dystonia fall in that category. So DYT1 is called autosomal dominant, meaning that there's a 50% likelihood of the offspring of someone with this to develop the same dystonia, typically presenting in the first decade of life, often affecting a limb, arm, or leg. So that's different than adult onset dystonias, which are typically head and neck dystonias. The risk of spread of dystonia is related to age, so higher risk in younger patients and the site of onset. So if the dystonia starts in the leg, it's more likely to spread to involve other parts of the body. And this has been classified as involving a single deletion in an amino acid in a protein called torsin A on chromosome 9 that results in this dystonia. DYT5 is also autosomal dominant. The onset is, again, in the first decade of life, typically affecting the foot, worse later on in the day, better after sleep. There's an exquisite response to low-dose levodopa. And so when we see a young person with dystonia, then even without doing genetic testing, we'll often use low-dose levodopa to see if the person improves. Levodopa gets converted directly to dopamine, and it then helps to modulate those dopamine pathways in the basal ganglia to then provide improvement for these patients. Most cases are due to mutation in the CTP cyclohydrolase 1 gene. So this dystonia has been also well defined and described and can be assessed with a genetic test. And then myoclonus dystonia, this is also called DYT11, also autosomal dominant, onset of symptoms late in the first or second decade of life, tends to affect the upper limbs and neck, and these myoclonic jerks can be very pronounced. This type of problem can also go undiagnosed for years. So I have one patient who she was thought to have a type of epilepsy because of her diffuse jerking movements that for several years she was treated with anti-epileptic drugs. When then it came to attention that she was also having some focal dystonia in her neck and limb. And that then resulted in her undergoing genetic testing and being properly diagnosed. And this condition is linked to mutations in the epsilon sarcoglycan gene. So in terms of workup that's needed, some of the most important things to do are to review prescription medications that are being used. So the D2 receptor blockers, I mentioned the anti-nausea medication, Reglan, antipsychotic medications such as Haldol. We do blood work to exclude other neurological disorders that can lead to dystonia, like Wilson's disease, which is a problem of abnormal copper deposition in the liver. Genetic testing for selected patients is done, for example, the DYT1, 5, and 11. And then imaging is done for all patients with hemidystonia, because then we always need to exclude the possibility that there's a structural abnormality that's resulting in their dystonia. So now we'll move on to treatment. Botulinum neurotoxins are the very effective treatments. They're currently the only FDA-approved treatment for cervical dystonia. And botulinum neurotoxins work to reduce the excessive tone in the muscle by blocking acetylcholine. So acetylcholine is released from the nerve ending to the muscle. It activates acetylcholine receptors on the muscle, and that causes the muscle to contract. So botulinum toxins block that acetylcholine release, and thus the muscle doesn't contract. So even though the muscle is receiving the signal from the brain to it, the muscle is not contracting as much. For cervical dystonia, 50 to 90% of the patients experience improvements in dystonic symptoms and dystonia-related pain. 70% of the patients report pain relief after 3 treatments, with a mean time to pain relief close to 7 days. So that's how long it takes to kick in. And I tell patients it's really important to not just have one treatment, because as with any medication, I tend to be conservative, and my colleagues do as well, that it's better to increase the dose with visits 2 and 3 instead of just trying to get the maximal relief with that first visit, because we don't want to induce side effects. So we'll start lower than we think the person will need and then build upon that. So 3 treatments by then we sort of found that zone whereby patients have good improvement. Improvement can be seen as early as 1 to 14 days. Peak response 2 to 6 weeks after injection, and usually wears off 10 to 12 weeks. So that's when we would see the patients back for re-injection. There are 4 botulinum toxins currently FDA approved for cervical dystonia, and then some for other types of dystonia selectively. There is Botox, Dysport, Xeomin, and Myoblock. They have different properties to them. So some are more acidic than others. Some are available in liquid form, others in a powdered form. Some have to be refrigerated, others not. And what we do know is that there's similar efficacy for all 4 botulinum toxins. So which type is used is based on the clinician or insurance preference. So it's sort of analogous to the Moderna versus Pfizer vaccine. They have similar efficacy. You know, and when you ask like, oh, what vaccine did you get? To your colleague, they may have gotten a different vaccine than you, but it really shouldn't matter that much because they're equally effective. So it really depends on who you're seeing as to what type of toxin you'll be given. That being said, there are patients who may respond better to one than the other. So if a person after 3 treatments doesn't respond well to one toxin, certainly they can and should be switched to a different one. Now, I mentioned that patients typically come back 10 to 12 weeks, and that's a source of frustration as well, because if a visit is 12 weeks from the last and it wears off at 10 weeks, then what do people do for those 2 weeks? It's certainly something that we're very aware of for patients, that last 2-week period before they come back. But there is some good news in that late last year, there was a phase 3 clinical trial that showed treatment of cervical dystonia with a new type of botulinum toxin, DAXI botulinum toxin type A, that provided clinically meaningful and long-lasting relief of pain and reduction of disability with duration of effect of 24 weeks. So we're looking at really doubling the amount of time that the effect is lasting, which would be wonderful, and especially in our state where, in the wintertime, if there's a snowstorm and patients can't come in for their toxin therapy, then that's a problem if they have to be rescheduled. If they have a longer lasting toxin, then that would be of great benefit. So there's certainly more to come about this toxin in the future. Oral treatments include anticholinergic. So these have been, these were the very first treatments used for cervical dystonia. So the benefits are well described. The dose is titrated until benefit is seen or until a dose limiting adverse effect is seen. These medications can cause dry mouth, urinary retention, blurred vision, confusion, hallucinations. So they're not the easiest medications to use, in particular with our older patients. So they're not first line. But examples include trihexyphenidyl and benztropine. Baclofen is another commonly used medication. This works via the GABA-A-B receptor in the cerebellum and brainstem and spinal cord. By activating that receptor, agonist means that it activates the GABA-B receptor. This inhibits the release of glutamate and aspartate, which are excitatory neurochemicals that are involved in generating pain and activating the acetylcholine release, for example. This then helps to alleviate skeletal muscle spasticity and pain. Unfortunately, it doesn't work as robustly as we would hope. Sometimes as little as only 11% of patients with cervical dystonia, for example, are on baclofen alone, and they often need a secondary agent to go along with that. As we increase the dose, that might be dose limiting because patients may mention fatigue, which is number one side effect, or some other issues such as dizziness. Rarely intrathecal baclofen, whereby baclofen is introduced directly into the spinal column, has been reported to be more effective in patients with cervical dystonia, especially those who don't respond well to toxin therapy, that they need something more. Intrathecal baclofen can be used. Benzodiazepines are another category of medications. These also work on the GABA receptor, that inhibitory neurochemical that blocks excessive neuronal signals. This has muscle relaxant properties that may be beneficial in up to 21% of patients with dystonia. In those who have a prominent head tremor, they're often very helpful. So in my practice, I'll often combine clonazepam, Klonopin, with botulinum toxin or one of the other medications in patients who have a dystonic head tremor. The Klonopin works very well for that purpose. Benzodiazepines at higher doses can cause sedation, so that could be also limiting. The dopaminergic medications, we mentioned those, that for the dopa responsive dystonia, DYT5, it is the treatment of choice by far. In many cases, use of levodopa can allow a person with dopa responsive dystonia to have full functionality, including walking, running, speaking, writing, and its effectiveness is long-term as well. So with levodopa, in its use for other neurological conditions like Parkinson's disease, as over time, levodopa may have side effects such as dyskinesia, but with dopa responsive dystonia, its effectiveness is maintained without that type of long-term side effect, which is great since these dystonias start early on in life, and we know that patients can be on them long-term. for my DYT5 patients, I may go a full year, like we may just do a yearly visit because they typically do very well. That I don't need to see them more than that, which is wonderful. Then there is deep brain stimulation, and I'm just going to touch on this briefly. I mean, this can certainly be a talk in and of itself, and in fact, the DMRF is sponsoring a talk on deep brain stimulation, so you may hear about that later for those of you who want to register for that program. But I'll just touch on that very briefly. DBS of the globus pallidus is an effective treatment for DYT1. It may help with other forms of dystonia, including cervical dystonia. So here just shows a schematic in that middle diagram of the lead going into the globus pallidus. And then the way this is done is that that electrode goes into that part of the brain. In the stage 1 procedure, stage 2 is whereby a wire is inserted underneath the skin all the way to a second incision in the chest wall where a pulse generator is placed. And then that pulse generator delivers a specific current at a specific frequency to help in that, undo that synchronous activity that's resulted in the dystonia. So it desynchronizes the cells to allow restoration of function. So for DYT1, a very large scale study that was published a few years ago showed symptom severity was reduced to less than 20% of baseline after 2 years of DBS therapy. So very highly significant result. Disability scores reduced to less than 30% of baseline. 61% of the patients had discontinued all dystonia related medications. So for DYT1, bar none, it's the most effective treatment to date. And so when patients are diagnosed with that condition, then that's certainly something we discuss with them. For cervical dystonia, there are some smaller trials, and these are patients who are really refractory to all other options. So I have one patient that I can think of in particular who I've offered DBS to recently, who's really tried several of the oral medications, several of the different botulinum toxin injections. And so she's at the point where cervical dystonia, for DBS for her cervical dystonia would be quite beneficial. DBS has been shown to provide significant improvements in a clinical rating scale that we use called Twisters, and then the subscore for pain. So 50% of people experience a reduction of pain at 32 months, and 6 of 10 patients in this study considered to have a good response. Then in terms of other treatments, acupuncture can be used. So studies have found that acupuncture is safe and feasible as an adjunctive therapy. In a large-scale study of acupuncture for chronic neck pain, it included a cohort randomly assigned to no acupuncture, and greater relief was seen in those who received acupuncture. And we do recognize the value of acupuncture in our center, the Chase Family Movement Disorder Center. We have this as an option for our patients who are seen in Vernon, Cheshire, or Mystic, that we have acupuncturists on site to see our patients. And we actually offer, through a grant program, 3 sessions of acupuncture free of charge to our patients. So this way they can try to see if it's a value to them, and without any charge whatsoever. So it's a really nice additional treatment option that we can offer our patients. Cannabis is sometimes brought up by patients, but per the American Academy of Neurology guidelines and per several studies to date, there's not been sufficient evidence to demonstrate this as an effective treatment. So although it's used for other neurological conditions, there's just not sufficient benefit in cervical dystonia. So here, the one treatment I left out is that of physical therapy. So I'm going to turn it over to my esteemed colleague, Megan, who will review that with you. And I really appreciate, again, your time this morning and your attention. And I'll turn it over to you.
share. There we go. Good morning, everyone. So hopefully you can all see my screen here again. And that was a wonderful introduction. Thank you, Dr. Machado. And I hope that everything will now flow right into my presentation here, talking about physical therapy for cervical dystonia. I do work in the Vernon Hartford Healthcare Rehabilitation Network, and I have had the pleasure of treating a lot of patients with cervical dystonia. So I'm going to go through now what we typically are doing for these types of patients when they do come to see us. So the objectives of my presentation today are for you to hopefully understand the importance of a holistic and multidisciplinary approach to the treatment of cervical dystonia, and become familiar with some of the evidence that exists for the treatment of cervical dystonia with the use of physical therapy, and understand how, as a physical therapist, we incorporate different types of training and treatment, including learning-based sensory motor training, and then how we're really looking and doing a systematic approach to our training for treatment of cervical dystonia. So as I was saying, physical therapy is just one piece of the puzzle. We're just a member of the team. Typically, physical therapy is going to be done as an adjunct to Botox. So that will usually be referred to physical therapy after having been seen by the neurologist, or in our case, the movement disorder specialist, after you've received your Botox injections, or when you've originally received the diagnosis. And then in terms of after you've had Botox, usually what we'll do is we'll schedule therapy to have occurred 10 to 14 days after having received those treatments. But there's also other pieces of the puzzle, including occupational therapy and speech therapy. So for some of the different types of dystonias that Dr. Machado mentioned, including that focal hand dystonia or any of the issues with voice, occupational therapy and speech therapy might be appropriate. But it's also very important to remember how fitness plays an important role. So making sure that you're participating in regular exercise, just like you are recommended for all your other medical diagnoses, getting regular physical activity 3 to 5 times a week is going to be helpful. Also making sure that you are getting enough sleep and that your diet is healthy and it's nutritious and that you're really making sure that you're receiving all the nutrients that you're supposed to. And then mindfulness. So we'll talk a little bit about this as we move through some of the presentation, but making sure that you're in a good headspace to be able to accept and to work on some of these different areas of your brain, mind, and imagery to see if you can help make and affect a positive change. So in terms of some of the evidence that's out there to support physical therapy, physical therapy is one of those professions where we've been doing things for a very long time, but we don't necessarily have some of the literature and the research to support it yet. So there is rather limited research out there. And one of the problems is that most of the studies that have been completed have been case studies or very, very small studies. They've also been non-randomized because giving someone the treatment of physical therapy, you can't blind that. So somebody is going to know that they're receiving physical therapy. So it can be somewhat hard to make these, to complete this research in a blinded fashion to make it objective. Still, research has been done, and in 2014, they looked at 16 different studies, and what they found was that some of the physical therapy techniques that were being used and that had positive outcomes associated with them included the use of sensory tricks, which Dr. Machado had talked about, so that hand on the chin, arm over the head, or any other different things that you may use to help kind of quiet down any of that dystonia. There's also been some studies showing the use of surface EMGs and or biofeedback, so helping with some of that inhibition by being able to hear how active those muscles are, or overactive in this matter, to see if you can then quiet them down. There's also been use of muscle vibration and or sensory stimulation, so using a TENS unit or a small vibrator on the overactive muscle to see if it'll quiet it down. And then body awareness and perception. So I think it's a great thing to look at some of these different studies because, like Dr. Machado said as well, this isn't not a one-size-fits-all type of approach. So certain aspects of these different things may help different patients at different times throughout the course of their disease and at different points of where they are in terms of their treatment. So really what we need to do is be aware of the things that we have available and be able to use them as we see appropriate. So one of the ones that we're going to look at most right now, and that has actually been quite impressive in terms of how physical therapists shape their treatment, was a paper that was released in 2008. And it looks at learning-based sensory motor training for focal dystonia. And this really has shaped our treatment. It is specific to task-specific focal hand dystonia, but what it does is it gives us a kind of a treatment framework of how we want to approach our patients. So this learning-based sensory motor training has 3 different aspects that we're looking at. So there's the setup, the preparing of the brain, the work that you're actually doing to train the brain, and then how you're treating those underlying factors. So in terms of the setup, preparing the brain, this is the most important step. So Dr. Machado mentioned earlier that the underlying pathophysiology in cervical dystonia and any type of sensory dystonia is that there's that excessive excitability and there's that decrease in inhibition. So our nervous system is just in a heightened response and it's not able to calm itself down. And that neuroplasticity, or that change that's happened in the brain, it's gone awry. So if we are going to make a change, we need to really address that problem. So we need to get the brain ready to learn. So how are we going to do that? How are we going to set the brain up? So some of the key components of getting the brain ready to learn and to make these changes include talking about enhanced expectations. So talking with the physical therapist, the occupational therapist, the speech therapist, that this is going to work. People with cervical dystonia, people with focal hand dystonia improve with this type of treatment. So getting the brain ready to accept this type of treatment and really having the buy-in that this is going to work. If you come in for therapy believing that it's not going to work, you're probably right. You need to fully believe in this and be ready and willing to participate. The next part is providing that autonomy. This isn't going to be something where you come in and you're going to be a passive participant. You need to be an active member of the team here. And that might be certain things, including you deciding, okay, you know what, today I want to work on being able to hold my head up while I'm sitting so that I can make sure that I'm able to participate in eating a meal out with family or friends, or being able to go out with friends and assume a different posture. But having that autonomy and having that choice and being an active participant is very important. However, we also now need to work on quieting that nervous system. So we said that there was that excessive excitability. So how can we get the brain kind of calmed down and ready to learn? And there's different things. There's mindfulness, yoga, working on different types of breathing, mindful meditation, rocking, swaddling, listening to calm music, any of those things, getting you in a position where you're ready to learn. And then finally, imagining normal movements with joy. So some of that mental imagery is going to be very, very helpful in terms of being able to get the brain prepared and ready to learn. If you can, one of the options could be capturing a video of you. Everybody has cell phones these days and has smartphones, but taking a video of you when you're in a good posture, okay? And maybe it's when you're using one of those sensory tricks of either the thumb or the finger on the chin or the arm over the head, and then watching it, and then imagining yourself doing daily activities with that level of control and with that good posture. Seeing if then you can imagine yourself taking that out and doing it with everything else that you would like to be able to in your life. That mental imagery and that mental practice has been shown to be very, very helpful. Next, now that the brain is ready, okay, and we've got it primed and ready to go, we actually need to work the brain. So what we're looking to do is we're trying to stop or to inhibit, lessen any of those abnormal movements, and then retrain the brain. So first, like we said, we have to inhibit those abnormal movements, sorry. And we're going to do that by using, again, any of these different sensory tricks. So we have the picture of the girl here, and she's got the arm over the head, or it can be having the finger on the chin, or Dr. Machado mentioned the piece of cork in between the teeth. But we can also do these things by changing your position. So if it's happening when you're standing, why don't we try it sitting down? Or let's have you lie down so that your head is supported by the bed, and see if we can get you into a position where we can calm that down, inhibit those abnormal movements before we start, all right? Some other positions that we can try are hanging your head upside down, putting the head between the legs, lying on your side, all these different things. Also, the way that this works is when you're lying down now, you're getting that extra input into different parts of your body. When you're sitting up in your chair, if you're sitting in good posture and your feet are flat on the floor, depending on if your chair has arms, rests on it or not, you're getting that input through the bottom of your feet on the floor. You're getting the input through the back of your thighs as you're sitting on the chair, and then maybe you're getting some input from the back of the chair. But once you're lying down, all those other sensory receptors through your back and through your arms and now through your head are getting more input. So, as Dr. Machado had said again earlier, if there's that discrepancy in the brain and you're not getting that good input, or you're getting abnormal input from that different part, now if you can flood the other areas, you may be able to inhibit that abnormal movement. The other things that we can try for changing sensory input include using things such as TENS, which is the transcutaneous electrical nerve stimulation. So that's the use of electrodes that you'll place over different muscles, and it feels like a buzzing or a tingling sensation. The other things we can try include kinesiotape. So that's the picture of the gentleman on the left, and it's that black piece of tape. And if you watched any of the Olympics a few years ago, a lot of the volleyball players had the K-tape. And really what that's meant to do is to see if it can change that sensory input, also improve blood flow to the different area, or make an overactive muscle quiet down. We can also again use a vibrator if we have to. They have the little mini ones, and put that on an overactive muscle. Some other things that we can try as well are the use of a weighted vest. So having that, again, extra input and that extra weight put around the shoulders or around the chest can help to quiet those abnormal movements. So now that we've hopefully inhibited those abnormal movements, we can slowly start to retrain normal movements. And now we're not going to jump right into whatever the target task is. We're going to start smaller, and we'll start with that non-target task. One of the things that you can try include using different modalities or different environments, including an Alter-G or a pool. The Alter-G is a very fancy treadmill where you're kind of encapsulated, and then they're able to put enough pressure in there or take the pressure off so that you're almost weightless. So taking away those other physical demands, or the same thing in a pool. Now you don't have to worry about your balance, and you've got the assist of the water to give you buoyancy. And that's just going to change the task, and it might be what you need to be able to start and be successful. The other thing we can use is a mirror or a video training of someone else doing the task. So the mirror is going to give you more visual input so that you're able to see at the same time as feel what's going on. And having that, again, extra input can be very, very helpful in terms of helping you to retrain those normal movements. And then the video training is that mental imagery and that mental practice. So if we consider that the problem with the movement control might stem from that smudging of the sensory cortex, it's important to really improve the ability to identify and localize any of that sensory input. So we're going to want to improve that sensory and motor discrimination, improve the ability to identify and localize sensory input. So it might be different things where we're going to be touching. Where am I touching you on the neck right now? Is it behind the ear? Now I'm down closer to the collarbone. Now we're right behind at the back of your hairline. Really trying to focus in on being more aware of where those sensory inputs are. This can be done now with having someone else touching your neck, touching the arm, so that can be from the therapist, or even having you do it at the same time. This may be coupled with looking in the mirror. So again, now you're getting that visual input. You're able to see where you're touching, as well as saying it out loud. That can help with some of that sensory discrimination and really improve your ability to localize that different input. We also want to work on improving your motor control. And this might be certain things like, okay, we're going to turn the head without moving the rest of the body. Work on that ability to isolate that different movement. Being able to tilt versus turn versus look up and down. Doing these different movements can help, again, with retraining that brain. And we may need to do these things, as we spoke about a little bit earlier, in these different postures. So we might not start them in sitting. We might start them lying down on your back, lying on your side. Or we'll be doing them sitting, but you're going to be sitting on something like a physio ball where it's an unstable surface. Just again, to give that different feedback and really try to retrain that brain. Some of the other things we can do is work on that external focus of attention. So instead of saying turn your head to the right, it might be something, turn your head and look out the window. So that changes how that cue is processed in the brain. And having that cue is going to, again, hopefully improve your ability to complete that task. Overall, the true work of training the brain is going to be in the repetition and then the very gradual succession and progression of these different sensory and motor activities. There needs to be a very strong commitment to a home program. So as much as it might be nice to come in for fit therapy, get some heat on the neck, work on some massage, the true work is going to be in what you do once you leave the clinic, what you do at home. That's where you're really going to make and really see changes to really hopefully have those positive results. So practice, 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 practice. I can't say it enough. So that's talking about some of the neuroplasticity and what's going on in the brain, but we can't overlook some of these underlying factors, okay? We need to address the different biomechanics. So in physical therapy, we're going to analyze and treat your posture and your movement where the dystonia is the worst. So are you noticing that the dystonia is worse when you're sitting versus standing versus when you're walking? Do we need to look and see how does your alignment change when you're sitting? is that when you're sitting, you always cross your legs so that you're leaning off to the one side. So what happens now if we uncross the legs? Changes the posture and you're sitting up straighter. Does that make a difference? Looking to see then how your trunk and your pelvis and your neck, how are they all relating to one another? We need to address your strength. So because of some of the abnormal posturing that you might have, there's going to be some imbalances that can contribute to this. It could be that it's not even the imbalances are in your neck. It could be further away. It could be down in the pelvis. So again, if you've got weakness down in your pelvis or your trunk and you're constantly leaning over to the left side, is your head just trying to match to get you back to the middle? So once we correct you down lower, will the head fall into line? We need to make sure that we're looking at all of those things and making sure that we're addressing them. Flexibility. Is there a lack of extension or rotation that's coming through your spine that's contributing to this? What about what's going on in your hips? Is that contributing to it even further, influencing that head and neck posture? So we can't just treat the neck in a bubble. We need to look both above and below the chain and see if we can improve that posture. There's nerve mobility. Is there tightness? And in those different nerve patterns, is there tension that we need to address? Balance. All right, we'll talk a little bit more about this, but we need to improve your proprioception, so your ability to tell where you are in space, and that's something that can be affected. You know that your head is tilted off to one side or the other, but do you really? I mean, you've been told that, but can you sense that and feel that? And we'll talk about how we're able to measure that and check that. We also want to make sure that you're able to maintain your balance and prevent any type of falls. So we'll look at your anticipatory and your reactive balance. So some of the muscle imbalances that we'll see, they can be somewhat apparent, and we really definitely need to address them. But we might come to that chicken or the egg dilemma. Which came first? Did the muscle imbalance contribute to the development of the dystonia, or is it a result of it? Either way, we can't tell the difference. We need to address it. Okay, we need to work on those different things. We also want to be mindful of what your breathing pattern is. Are you someone that breathes from down in the diaphragm, or are you an upper chest breather where you're using all those little muscles up in your neck, and that's causing more activity? We need to be mindful and look at this. We also need to make sure that we're addressing and treating different personal factors. I've noticed that many of my patients who have cervical dystonia tend to be higher achievers, okay? And they can tend to be perfectionists. So getting to the root of some of that and making sure that we're exploring and addressing these potential factors can be very, very helpful in making sure that we can be successful in our treatment. So we had spoken a little bit about that proprioception and about the balance. So as physical therapists, we know that our balance and our posture is made up of multiple different systems. So our sensory motor control is all of the different input that we get from our eyes, our vision. Our vestibular system, which is our inner ear, and that's what responds to different head movements, side to side, up and down. And most people don't notice their vestibular systems until there's a problem, which is typically with vertigo. But that can be a problem as well as cervical dystonia. Then that neck proprioception. So our neck is full of different types of receptors that tell us if we're sitting up tall, if we're tilted to one side, tilted to the other. But are we really listening to that information, and are we able to process it? And then there's that other somatosensation and that other feeling that you're getting from your feet and in your ankles and your hips and your knees, that's telling you where you are in space. And what's happening then is your brain is taking all of that information together, and it needs to be able to synthesize it to then give us a motor command, and it needs to be able to then tell us what to do. And that then in turn gives us our movements. But if there's a mismatch, or if there is a problem with our brain's ability to process any of that sensory information, then our motor output is going to be changed. It's going to be disturbed. So we need to make sure that we're addressing all of these different things to be able to figure out how are we going to intervene and improve. So different tests that we'll do in therapy to assess these different things include looking at somebody's ability to feel and sense the different light touch on different parts of the neck, on the shoulders, on the feet. We're going to look in terms of the vestibular system. How are you able to turn that head side to side or up and down and maintain your balance? All of these different things, again, are going to influence how you're able to respond. So in terms of the balance and that somatosensation, one of the tests that we'll do is something called the Modified Clinical Tests for Sensory Integration and Balance. So in this picture here, the woman is standing above an A and B. She's standing on a firm surface. And if you notice in the first one, she has her eyes open. So when we're standing with our feet on a firm surface and our eyes open, we're getting great information from our feet about where we're standing. We're getting good visual information because we're standing still so we can focus on a target. And our head isn't moving very much, so our vestibular system is in a rather quiet position. But we should be able to maintain our balance here. In position B, she has her eyes closed. So now she doesn't have any visual information, so instead she's relying a lot on that somatosensation and that proprioception. Is she able to maintain her balance in this position and keep herself upright? If she wasn't able to, we would be concerned that she was having difficulty with being able to sense where she was, and we would say that she was probably dependent on visual information to maintain her balance. So again, this is great information for us to know for physical therapy, because this would be an area that we would want to address. If you're not able to maintain your balance with the eyes closed or with that absence of visual information, we need to improve your ability to maintain your balance and use those sensory cues without your vision. Now in C and D, she's standing on a compliant surface or on a foam surface. So now if she were to rock forward or rock back, instead of it being a hard stop, there's going to be some give to it. So in these positions now, she needs to be able to use that inner ear, that vestibular system, to help keep her upright. So in position C, her eyes are open, so she's getting good visual information, but her feet are on that compliant surface, so she's not going to get as good of somatosensory information. And then in position D, her eyes are closed. So in this position, no visual information, and she's not going to get accurate information from her feet. So if she's not able to maintain her balance, we know that maybe that vestibular system isn't up to par, or that she's not able to kind of use different cues to help her keep her balance. So doing this test is going to give us a lot of input about how someone is able to use these different sensory cues to keep them in an upright posture. One of the other tests that we do is something called the mini best test. So the mini best test is comprised of a bunch of different things, including some of the components that we just looked at in the modified CTSIB. But this other part of the test that they're doing here, what they'll have someone do is, you can see that in the first block, the woman has her hands on the other woman's chest, and the woman is leaning forward. And what's going to happen is the woman's going to lean into the hands, and then the woman's going to take her hands away, and we're going to see if she's able to anticipate that and take a step and maintain her balance. So then in the center one, she's leaning backwards, and we want to see if she's able to maintain her balance. And in the last one, she's leaning sideways. So again, how are you able to respond to these different perturbations, and what is your awareness of where your body is in space, and how are you able to use those cues to help you keep your balance? So one of the other tests, or the last test that we'll do, is something called the joint position error test. So as you can see in this test right here, there's an individual, and she has a headband on, and there's a laser pointer affixed to that. And then on the wall is a target, and in the center of the target is the green, and then there's rings. And each ring out is about a 1 degree. So for in the green, there's 3 different rings, and there's a 1 degree, 2 degree, and 3 degree discrepancy. And then out into the yellow would be 4.5 degrees out. And then in the red is 6 degrees. So what you'll do with this test is having someone either sitting, standing, or perhaps even lying down. What we want to try to do is position someone in a neutral posture so that that laser pointer is directly in the center. Okay, and this is usually the target is 90 centimeters away. And what's going to happen, or about 3 feet, is you're going to position someone so that their head is in neutral and the laser is in the center of the target. Then what we're going to have someone do is close their eyes, and we're going to ask them to turn their head as far as they can to the right. Keeping the eyes closed, you're going to have them then try to come back to the middle and have that laser pointer go right into the center of the target. So as we discussed with the earlier test, when someone has their eyes closed, they're not going to have that visual information, so they're going to have to rely on what the receptors in their neck or what that vestibular system is telling them to help reposition it. And what we'll have them do is we can retest it 3 different times, side to side, and then we can also do it up and down. And if someone is not able to reposition that laser back into the green, and they're out in the yellow or the red, then we know that there is a significant lack of ability to reposition that head in neutral. So it's a way for us to kind of objectively measure how you are able to reposition your head and what your awareness of your neck posture is. But then it also becomes a very useful training tool, because now what we can do is we can work on doing that same thing, but with your eyes open. So now we can practice this, having you turn the head and seeing if you can reposition that laser right into the center. And working on this in lying down, on your side, sitting up, or standing can be a very, very powerful tool. All right. If you can really become better aware of where your body is in space, hopefully you're going to be able to improve your ability to hold those postures and those positions. We can make this easier or harder depending on, again, if you're sitting or standing, but we can also do it now standing on that foam surface that we talked about, or do it sitting on a ball. Any of those different things are going to change the demands of the task and change how you're able to hold the head. So overall, for physical therapy, these are some of the great things that we'll hopefully use to assess your ability to maintain your head in the central posture. But we'll also look at different things, including what your active range of motion is. We'll measure how far you're able to turn the head one side versus the other, up and down. We'll also be mindful of asking how your pain is, and then really trying to develop a home exercise program that is meaningful to you, something that you're going to want to participate in and be an active member of making sure that you're completing. Because as we said, if you are not an active participant and if you don't buy into the exercises, then we can pretty much guarantee it's not going to work. This is just another picture of what that target looks like, so you can see the different rings and how we're able to grade it. So again, anything outside of that yellow ring is greater than 4.5 degrees, and that's something that is found to be outside of normal. So again, I work for Hartford Healthcare Rehabilitation Network right in Vernon. My email address is there. And thank you very much. And if anybody has any questions, I think we're ready. And then I also just included a list of some of the references of the different things that I was looking at if anyone is interested. Very good.
Thank you, Megan. That was fabulous. And Dr. Machado, thank you for that really wonderful overview and information on the various treatments that are available. Both presentations have given us a lot to think about. So you won't be surprised, but we received a number of questions in advance. So thanks to everybody who provided those questions in advance. And if you have questions now, please feel free to put them either in the Q&A or the chat box. But the first question we got in advance of the program this morning was, Dr. Machado, I think for you, can you explain the differences in getting your botulinum neurotoxin shots with EMG versus ultrasound? Is one better than the other? This person is getting EMG, but they heard in a chat room about somebody getting it via ultrasound, and they wonder if maybe that's better.
The short answer is no, that there's one has not been found to be superior to the other. It's more so related to the injector. So as an injector, we're trained differently. So some of us have been trained to use EMG, others to use ultrasound, and others to rely predominantly on anatomical guidance. So if a person has been trained in fellowship, for example, to use EMG, then that's what they're going to be most comfortable with, and they will be less comfortable with using ultrasound. And so and vice versa is true as well. And that goes for any of the muscle groups. Now, certainly there are some muscle groups that are deeper, for which a technique like EMG might be superior. But for the most part, either technique can be used. And again, it depends on the individual neurologist and how they were trained and what their expertise is in.
Great, thank you for that. Megan, next one is for you. What is mindfulness? Can you explain, just define that?
Sure. So mindfulness, it's thinking about your body and being aware of where you are in space. So sitting down, feeling your bones sitting on the chair, feeling how your vertebrae are stacked one on top of the other, and feeling the weight of your body, and being aware of and mindful of where you are basically, and how you exist in relation not only to yourself but also to your environment. So feeling your head on your shoulders stacked over top of your hips, and how your chair is situated on the floor. So really being present and being aware of where you are in space and how you relate to it is being mindful.
Great, thank you for that. Dr. Machado, you talked a little bit, and I thought your analogy was perfect about the difference between Moderna and Pfizer vaccinations. But we got actually a couple of questions about, is there one toxin that's better? And you addressed sort of changing toxins after 3 rounds of injections if it doesn't work. So is this something that the patient should suggest to their physician if the physician's not suggesting it? So could you just address the difference between the toxins and maybe changing?
Yeah, so with this question, the initial toxin that's chosen, especially for something like cervical dystonia, where all 4 are FDA approved for that purpose, it also comes back to what we just discussed, and that's training. So if a person has been trained to use a particular type of toxin, then that person may turn to use that toxin as the initial one. Um, and so, for example, it's well known that uh, Botox has been available for a longer period of time compared to some of the newer toxins like Dysport. And so it's unfortunate, but some neurologists may not have used Dysport in the past. They may not be familiar with its use, and so they may not offer it as an option for patients. And so if you've tried Botox, for example, and not getting sufficient benefit, it absolutely makes sense to switch to try a different toxin. So while they all have similar efficacy, I've mentioned that one person may just respond better to another, and those factors could be related to the pH of the medication, how complex the medication may be. So, for example, uh, Botox is a larger protein molecule compared to a different botulinum toxin called Xeomin, where the complexing proteins have been removed and it's a more purified form. So it's a smaller and may diffuse over a broader range. So if a person, again, is not getting sufficient benefit with Botox, may consider switching to another one like Xeomin to get a greater diffusion of the medication into the muscle groups. So switching again makes sense, and if the patient needs to bring that up, I don't think there's anything wrong with that. The patient shouldn't be shy or shouldn't think, well, I feel awkward to mention it to my doctor. Should we try something else? That's perfectly within reason to discuss continuing to receive the same therapy if it's just not helping sufficiently.
Thank you. I think it also points out the importance of making sure that you're aware, that patients are aware and knowledgeable of what their treatment options are to have that conversation with their physician. So thank you for that. Next question is for you as well. You talked a little bit about cervical dystonia and deep brain stimulation. Who's eligible, and what's the best cervical dystonia patient for DBS?
Yeah, so deep brain stimulation right now for dystonia it's a not fully FDA approved, so it's under the a medical exemption type of category, which means that institutions that use DBS for dystonia have to get special permission from their institutional review board to provide that as an option. That is set up that way so that it's clear that DBS is not a first line treatment for dystonia. And for my own patients, they truly have to try and not have sufficient benefit from all of the types of modalities we discussed. Everything from different botulinum toxins to different oral medications to courses of physical therapy. If those are not sufficient, then they may be considered for deep brain stimulation. The age category, the cutoff generally is age 80. So if they're above the age of 80, then they wouldn't be considered. They have to have a sufficient cognitive capability. So if there's any cognitive dysfunction like early dementia, then they wouldn't be they wouldn't be good candidates. There can't be any significant mood disorder. So if a patient has a significant anxiety or depression, that needs to be treated first, because we know that deep brain stimulation may, in rare cases, exacerbate that. The patient also has to be medically fit. So if the person has heart disease and is on anticoagulation, and that cannot be easily stopped for an elective procedure like deep brain stimulation, then that person would not be a good candidate. So overall, once patients get to the point of trying all these modalities, we go through that criteria, that screening criteria, and then there's 3 steps from there: obtaining an MRI of the brain, obtaining what's called a neurocognitive evaluation, So actually seeing a neuropsychologist to undergo a 2 to 3 hour assessment of their cognitive function and mood, and then meeting with the neurosurgeon. At my center, as with other high volume deep brain stimulation centers, then we meet as a team once a month to discuss every person that is being considered for deep brain stimulation. And then if there's a unanimous decision amongst the neurologist, neuropsychologist, and neurosurgeon to proceed, then we proceed forward. So it's a process, and it's a very well-oiled machine of a process. We really ensure that patients who undergo this process are going to benefit from the process.
Thank you. That was great. And thank you also for the shout out for the webinar that we have scheduled for April 20th. And I would encourage people, if they're thinking about DBS, the webinar is the patient perspective on DBS. So you'll learn from others who have gone through it. So we are happy to send information out to everybody. We have botulinum neurotoxins are being used for a number of other health issues. And we have a question from somebody. If you're getting Botox injections for cervical dystonia, can you get Botox for other issues as well?
So the key in that question is can you get Botox for other indications? And the answer is yes. So Botox, absolutely. Now we administer it truly head to toe as well. So it could be administered by not administered not only in a number of body areas, but also by a number of specialists. So that's important to keep in mind. So I'll give a recent example of a patient of mine who I've been giving myoblock for this person's dystonia, and the person had been responding well. Unbeknownst to me, the person was seeing a urologist in an institution not affiliated with mine, and the for overactive bladder, the urologist then used Botox into the bladder wall to relax the bladder so the bladder wouldn't constrict and expel urine to relieve the symptoms of overactive bladder. The problem was that Botox was administered sort of after about 2 months of the myoblock, and the person then came to me and said that my injection wore off so much earlier than I usually would. I've been struggling the last month. And then she mentioned, well, I received Botox for my bladder. So I said, well, that's where the problem lies. So one cannot mix toxins. It's like taking two medications from the same category, like taking Lipitor and Zocor for cholesterol. You wouldn't take two medicines in the same category because there could be a problem in that regard. So in that case, we ended up for the next treatment cycle to synchronize the toxin delivery and type. So that's important. So if you are getting toxin in another body part, synchronize it with whoever else is giving that toxin, and make sure it's the same toxin. Even myself, I may treat cervical dystonia and treat sialorrhea, which is excessive drooling, at the same time. So I'll administer the same toxin, even though it's in different body parts, one in gland, one in muscle, as long as it's synchronous and of the same type.
Great, thank you. And Megan, you talked a bit about practice, which seems to be a general rule for all of us in many things. Question about how often someone should see a physical therapist to actually begin to feel the benefits of PT for dystonia?
So that's one of the things that, unfortunately, with the lack of research, we don't really have a good understanding of what the ideal dosage is. And that's going to really depend on the patient and the therapist and how you are able to develop your treatment plan. Typically what we'll do is we'll see someone 10 to 14 days, like we said, after they had their injections of Botox. And then what will typically happen is teaching them an exercise program. And it's going to be a matter of determining when there's that level of comfort and feeling like you are able to continue with those exercises independently. Oftentimes what we'll do is we use what we sometimes call the dental model, where we have someone come in, do their exercises, teach them, and then they're discharged, continue to do their exercises at home, just like you would brush your teeth when you leave the dentist, but come back in for a checkup for us to be able to monitor and see how you're doing, progress any of the exercises if we need to, and then discharge you again and have you go home and continue those exercises. So I don't, there's no hard and fast rule in terms of any of that, but just like you brush your teeth twice a day to keep cavities away, you're going to want to exercise regularly and consistently to hopefully help maintain any of the gains that you do achieve during therapy.
Yeah, that's a great analogy too. So
yeah,
is there benefit for people to video themselves while they're doing the exercises to make sure that they're actually doing them properly?
Absolutely. And that kind of goes back to then that mindfulness and being aware of it, but then also getting that visual input and being able to see yourself and then being able to imagine yourself doing those exercises and then being able to watch them back and do that mental practice. So yes.
Yeah, great. Thank you. Dr. Machado, you gave a wonderful overview of the genetics, what we know about genetics and dystonia at this point. Where can somebody get genetic testing? How do they go about that?
Now, there are multiple different companies that provide genetic testing. So the individual person's neurologist, movement disorder specialist can order that testing. The great thing that's happened recently is that as the number of different companies have expanded of those who offer this type of genetic testing, so has the price of genetic testing dropped because with increased competition, there is a drive towards lowering the price to keep the competition going. So for example, one testing company that I frequently use is called Athena Diagnostics, and their dystonia panels used to be quite expensive, and they recently and fairly dramatically, but sometimes 60, 80% of a price decrease over time. Why I mention price is because there may be times when an insurance company may not cover the costs of the genetic test. And so price does factor in significantly as to whether a person would actually undergo genetic testing. For young patients, so those in their teens and 20s and sometimes 30s, I really highly encourage genetic testing because it will help to discuss prognosis and treatment options moving forward. And as I mentioned, that the testing can be obtained by speaking to your neurologist and going through a variety of different options. But Athena Diagnostics is the one that I typically turn to.
Thank you for that. And getting insurance companies to cover genetic testing is something that we work on through our advocacy program, and we'll talk a little bit about that later. So we had a question from somebody about whether or not this program is being recorded, and yes, the answer is yes. And then everybody who registered will send you the link out so that you'll be able to watch it later. I know for myself, I like to watch programs over and over because you miss things. And so these will be available on the Foundation's YouTube channel. And then Dr. Machado, you mentioned cannabis and dystonia. This is I don't think we've done an education program without this question coming up. So kudos to you for actually raising it in advance. This person says that they have found relief for some of their pain of the cervical dystonia. And you talked about the American Academy of Neurology's statement on this. For those who are finding relief, do you have general advice should they let their doctor know? Is there general guidance around the use of cannabis for those who are finding relief with it?
Yeah, no, it's a great point. And it's a complex point as well, because what I refer to in my talk is that in the clinical trials done to date, there have not been a statistically significant results seen, and that's why cervical dystonia does not appear on the list of diagnoses for which medical cannabis is approved. but that doesn't mean that it's not helpful. And I clarify that by saying that patients often don't have cervical dystonia or another dystonia in isolation. So patients may have cervical dystonia and osteoarthritic disease or cervical spine disease of some other type. And cannabis is shown to be helpful for degenerative disorders of the spine and muscle spasm conditions. It's helpful for anxiety, helpful for sleep. So even though it's not helping directly the actual dystonia, what's happening at the level of the brain in that neural circuitry I explained, it's helpful for the other concurrent issues that the person is having. So if a person is finding benefit from medical cannabis, then by all means, like I don't if a person brings it up, my response is, long as barrier, and certainly they may try it. And if they find benefit, then the issue comes down to finding the right dose, if you will. We still don't know a lot of things about dose with medical cannabis either. And that comes to formulation, because there are different formulations of cannabis, and then also what would be proper to use in terms of whether it's an oil, a tincture, an edible, and then how much and how often. All those questions we don't know, but working with a pharmacist at the dispensary can help answer some of those questions. And again, if it's helping indirectly some of the symptoms that are then directly impacting on the dystonia, if it's helping to break this cycle of pain or discomfort, absolutely, then I would say the person can't continue using.
Right. Thank you. And we, as an organization, always recommend that people share that information with their doctor so that the physician has the complete picture of what somebody is medicating with as well. Same, I'm sure, relates to alcohol use for those who get relief from alcohol too. So that exhausts our questions. You both did such a wonderful job, comprehensive overview. Thank you so very much for your time in preparing for this morning's program, and also for the work that you do every day and helping people successfully manage their dystonia. We're grateful to both of you. Thank you for being a part of this program this morning.
Thanks so much.
Thanks for having me.
It was a pleasure. Thank you.
Good.
We are now going to move to information on the foundation, and specifically helping to highlight a couple of programs that we've talked about a little bit this morning, our advocacy and our support program. So I'm going to try to do this as smoothly as Dr. Machado and Megan did. And hopefully everyone can see this. So again, I thank everybody for sharing part of your Saturday with us as the temperatures get warmer, and it's nice to be outside, which I understand you're having a beautiful day in Connecticut. Saturdays are precious time, so thank you for being with us. What I'd like to do this morning in the time that I have is just provide you with an overview of the DMRF programming, a little bit of our history, and then, as I said, focus on support and awareness. So this is pictured here are our founders, Sam and Fran Belsberg. They founded the organization 45 years ago. We're actually acknowledging our 45th anniversary this year. It's not something that we celebrate. We would much rather not be here because there's no need for the services of the foundation. But we do acknowledge 45 years of service to the community. They founded the organization when their then teenage daughter was exhibiting some very strange symptoms. And perhaps like many of you, she got bounced around from doctor to doctor in pursuit of a diagnosis. And when they got the diagnosis of dystonia, they were grateful, but had never heard of dystonia before. So they wanted to form an organization that would focus on research, because 45 years ago, there were no treatments. There was no Botox at that time. And they recognized that science was going to be the path to additional treatments, and then ultimately our goal of a cure. But as parents, they recognize that the science can never move fast enough for everyone who's waiting for answers. And so they wanted the foundation to also be dedicated to promoting awareness and education. And then last, but certainly not least, having a strong program of support so that no one need to go through dystonia alone. Our science program, just very quickly, we're very proud of our science program. We have committed more than $35 million to research grants that are intended to provide that preliminary data that investigators can then take to places like the National Institutes of Health for more robust funding. Because we have a scientist on staff, we're also able to go to investigators and ask them to do little bits of pieces of research. So we contract with investigators. So if you think of dystonia research as a puzzle, a jigsaw puzzle, we may have some parts of that puzzle completed, and we think maybe we know the shape of some of those missing pieces. So our chief scientific advisor can go to an investigator and say, would you work with us to develop this missing piece? We think it has this shape. And if they agree to work with us, then we check in with them every 90 days to see how the progress is going. If we were wrong, or the progress is just headed in a different direction, we're able to redirect those funds to other areas of science. Whereas when we provide a grant, we're committed to that investigator who had that idea, provided it to us. It was reviewed by other scientists and given a score, and then approved for funding. We're committed to funding them and don't get our first report until they're 9 months into their project. So it's a little bit of a different relationship. Research fellowships reflect our commitment to supporting early stage investigators, young investigators, to keeping our intellectual pipeline, if you will, full. Trying to attract people to the dystonia research field, which is important. Many of the senior noted research experts trace their roots back to getting a research fellowship grant from the DMRF. We also think it's important to provide support for the training of physicians. So that we have more physicians out in the community like Dr. Machado, who can recognize what dystonia is early on and know how to treat it. So we have a clinical fellowship program. It's been in place now for the last 10 years. We have over 30 clinical fellows who are now out in the community who have been DMRF clinical fellows. Our science program also includes scientific meetings where we bring experts together to talk about a specific area of dystonia research, identify the gaps in that area, and then develop a plan for how we might address those. We also do larger meetings, like international meetings. In fact, we had one scheduled last year for June, which had to be rescheduled because of the global pandemic. It's now scheduled for Dublin in June of 2023. The Dystonia Coalition is something I'll talk about a little bit later, but it's an NIH-supported clinical research network. I skipped over working with industry, which I didn't mean to do, but we often work with the pharmaceutical industry to help them get their treatments out into the community so that you have and your doctor has more treatment options and expanded treatment menus. So we might help them with recruiting for a clinical trial, or we might help them in actually designing that clinical trial. So it's based in reality, and we're not asking people who are participating in the study to do crazy things. So we partner with industry whenever we can to make sure that they're continuing to focus on dystonia and bringing more treatments to market. The National Institutes of Health is the largest funder of biomedical research in the world. We want NIH to know that we're watching them, that dystonia is something that's worthy to be funded, that we have good scientists, and that we expect that they will be looking at dystonia research as a viable area for research. We're fortunate that we have terrific scientific leadership. Dr. Malin DeLong is pictured here on the far left. Dr. DeLong stepped down as our scientific director about 18 months ago. He's now our scientific director emeritus. Dr. DeLong did the preliminary work around the use of basal ganglia that Dr. Machado talked about as it related to DBS in his presentation. Dr. Gerald Perlmutter is our current scientific director. Dr. Perlmutter is at Washington University in St. Louis. Both of these individuals are really extraordinarily renowned researchers and wonderful, wonderful human beings as well. And then pictured on the right is our chief scientific advisor, Dr. Jan Teller, who works full-time with the organization to manage our scientific and research program. But I think it's also important to note that part of what Jan's job is to look at the entire neurological landscape, not just what's going on in dystonia. What's happening in Huntington's disease or Wilson's disease or Parkinson's disease that may hold promise for developing new dystonia treatments or research breakthroughs. We're fortunate that we have a group of scientists, our Medical and Scientific Advisory Council, pictured here, give generously of their time to help us review those grants that are submitted to us for funding, to provide oversight to our research and scientific program. Many participate in the scientific meetings I spoke about. This year, I'm really pleased to say these two individuals who are pictured here, on the left, Dr. Asif Sheikh, and on the right, Dr. Roy Silito, will serve as our co-editors-in-chief. The DMRF will launch later this month the first ever dystonia dedicated journal. We are very, very excited about this. Last year, there were over 1,100 dystonia studies published, but they were published in different journals. So they might have appeared in Tremor or Neurology or the Parkinson's disease journals. There hasn't been a journal dedicated just for dystonia until now. Doing this helps us to bring all of those studies together in one place so that our clinical and researchers can begin to see the work of others, help build collaborations, and hopefully help to connect the dots of what's going on out there in the research field. We're really excited about this. We think it'll help to expedite discovery. I talked a little bit about the Dystonia Coalition earlier. This is an NIH-supported grant. It has 44 clinical sites across North America and Europe. It is designed to help to reduce the barriers to clinical trials and getting new treatments to market. You'll see there on that second tier that the DMRF is listed. We serve as an administrative center for the coalition. We do this at no cost to the coalition because we think it's the right thing to do and we can do this. So we provide the grants to all of the coalition supported centers for the work that they're doing in support of the overall mission of the coalition. There's a pilot program, we pay out those grants. There's a career development program and we pay out those grants. And because we don't allow for what's called indirect, we've actually saved the coalition nearly $2 million of funds that have been able to be redirected into these scientific projects. Of note, this round, the coalition is now in its third round, is a development of a patient-reported outcomes app that will be used on a smartphone. And so you'll be able to eventually, once this is fully developed, be able to track the benefit of the symptoms from your botulinum neurotoxin injections. So sort of like a journal on your smartphone for you to say 5 days out, you feel your pain has been lessened, you know, 10 days out, you feel like you've got a full benefit of the toxin, and then begin to record when you feel like the toxin is wearing off. This information will be really very helpful to physicians like Dr. Machado and others going forward. So on June 8th, we will host a webinar. The speaker is Dr. Buzz Jenna, who is at Emory and who is the director of all of these activities. And Dr. Jenna will present the information on what the coalition has been doing for the last 10 years and how that's moving the field forward. So again, if you're interested in that, we'll make sure that you get that information. There is research that only you can do. And we hope that, that you'll consider participating. So the Global Dystonia Registry is a registry of patients from around the world who have, by enrolling in this registry, have noted that they're willing to participate in clinical trials, surveys that are being done by physicians, and that they want to be a part of sort of movement forward to get more treatments and ultimately a cure. You can unenroll at any time. The website is there. If you haven't checked it out, I encourage you to do so. We right now have about 6,300 people who are enrolled in the Global Dystonia Registry. The second one is to become a brain donor. Now, I say this cautiously to people in Connecticut and for people like Dr. Machado, who spent so much time at Yale. But if your mother wanted you to go to Harvard, there's still time. We work with the Harvard Brain Bank in collecting brains so that researchers can look at if there are any anatomical changes in the brain tissue as a result of dystonia. We can't do that while you're alive. And we hope that many, many years from now, you'll consider making sure that you made arrangements to become a brain donor. We make it easy for your surviving loved ones to do this. We have a staff person dedicated to this. There's no cost to the family. And it is really the ultimate contribution that you can make to our research effort. If you want more information on that, please let us know. We're happy to make sure that you get this. And then finally, I've listed here the www.clinicaltrials.gov website. Any trial that's being done in the US is registered at this site. So if you're interested in knowing what clinical trials are taking place for dystonia right now, you can check out that website. So awareness and education, wanting to make sure that you have accurate and balanced information is an important part of our mission. And as we talked about with Dr. Machado, we really think it's an important part of you being a partner in your developing your treatment plan. If you've never had the opportunity to visit the DMRF website, we encourage you to do so. The website address is there. It's full of really good information and the opportunity to learn about what's happening in the community. So please take some time to check that out. The Dystonia Dialogue is our magazine that comes out 3 times a year. We have an editorial board that provides oversight to the content of the dialogue. I'm pleased to say and thank Paula Schneider for her efforts with the editorial board. Paula has been an active member of the editorial board for some time. So if you have not, or if you're not getting the dialogue, please let us know. We would love to make sure that you get it. It's full of updates. It has research updates. It has advocacy updates, what's new in the community, and just some helpful tips throughout. So please let us know if you'd like to get it. Educational materials. It was really nice to see in Dr. Machado's presentation what we called a stick figure. It's a fabulous resource to be able to demonstrate the various forms of dystonia. All of our materials are updated regularly to reflect news and things that have happened in the community. They're all reviewed by medical professionals. And they're written in a way that is really designed to help patients better understand their form of dystonia and the treatments that are available to them. And we make them available to doctors at no cost because we want patients to be able to have them. If we were meeting together personally, which I think we all had hoped we would be able to do, we would have had samples of these available for you. So if you want any of these materials, you can go to our website and order them. We're happy to make sure that you get them. We've talked a little bit about the webinars. Dr. Machado mentioned the one that's scheduled for April 20th on DBS. I mentioned the one that we have scheduled on June 8th about the Dystonia Coalition. We'll have other webinars scheduled throughout the year. Pictured down here at the bottom, we have some of the webinars that we did last year. We did a research highlight. Dr. Perlmutter, our scientific director, sort of highlighted the advancements that the foundation has really helped to promote. We did a program on telemedicine last year because so many of us were having to see our doctors virtually, and we wanted people to get comfortable with that. And we were also fortunate to do a webinar on COVID and dystonia with Dr. Mark Hallett of the NIH and Dr. Robert Chen from the Toronto Western Hospital in Canada. All of our webinars are recorded and put on our YouTube channel. So they're all there for you to view again, like this one will be. Our commitment to the community is to make sure that you have good educational resources that you can use, that your family can use to help better understand dystonia. We do community educations programs, hopefully post-COVID, we'll be back to doing these in person. Zoom has certainly been a wonderful way for us to do outreach with educational programs, but there's nothing like being able to meet in person. It's just a wonderful thing. I think it helps to reduce isolation, and we hope to get back to that. Media efforts, the media is a fickle thing, and we try hard to get their attention and to help them understand how they can help us with our awareness efforts. Getting the attention of the national media is really difficult. We've had great success working with local media. So if you have a story that you'd like to share, we would like to work with you in getting that story placed locally. And then finally, the Dystonia Moves Me campaign is our program that we do every September. September is National Dystonia Awareness Month, and we plan various activities to help people raise awareness locally because we know that that really makes a significant impact. So support, we've talked a bit about support. Many people feel like they're in this alone. They've never heard of dystonia before. They might have gotten bounced around from doctor to doctor. At some point, they might have told them that it was a psychiatric illness. And it can be very, very isolating. We also have an incredibly generous community in that those who are affected want to support others because they have been through, many have been along the same path that those who, took 5-8 years to get a diagnosis. So we have support groups in Connecticut. We would like to develop additional support groups in Connecticut. If you're interested, please let us know. Paula has been a tireless worker in promoting support in Connecticut, and we have dedicated leaders who have been just terrific. Again, we're in a pandemic mode, so all of these support programs are being provided by Zoom, and I think going forward, we'll have some sort of hybrid of in-person meetings and Zoom meetings. I think we've all learned to appreciate the importance of sort of the human touch and human contact during these last 15 months. So we hope to resume our plans for in-person support group meetings, but we also have online forums. In addition to providing support this past year via Zoom, we have an online forum for people with cervical dystonia that has over 7,000 people in it. We have an online forum for people with generalized dystonia. We have a forum for parents of children with dystonia, people who have oral mandibular and blepharospasm, people in their 20s and 30s. You name it, we've got an online forum for you. And I think there's really it's important for people to be able to connect with others who are exhibiting similar symptoms and experiencing the same kinds of challenges. It's an opportunity to trade tips on how to cope, and just to be assured that, you know, you're having a bad day, but tomorrow will be a better day. And that's what our support grant program really does. We also have a physician referral. This is important, I think, for people who are new to dystonia and just don't know where to turn. They've never heard of a movement disorder neurologist before. How do you find one? This program is really designed to help them do that. Our support groups are also very important parts of that, so that you can have a discussion about, you know, I prefer a doctor who can take some time with me, who will explain things to me. And then there are others who say, I don't care what their bedside manner is, I just want the best. Those kinds of conversations take place in support groups and support forums. Dr. Machado talked about musicians' dystonia. This is a specialized form of dystonia, and we have a group specifically for musicians' dystonia. Many of them made their living from their talents, and now are not only facing the physical challenges of their dystonia, but also facing the challenges of now having to sort of figure out how they're going to make a living. We also feel very strongly about supporting our support leaders. Many, I would say probably most of our leaders are people who have dystonia themselves, and we want to make sure that they're not exhausting themselves by being a resource in that community. So next Saturday, we're actually doing a conference for just specifically for our support group leaders, to help them hone some of their skills, to give them information that they have identified as needing to be more of a resource locally, and to be helpful to all of those who turn to them for support. And then finally, we do a lot of outreach. It's important for people to know that they don't have to be alone. And in order to do that, we need to make sure that they know that we are here for them. Advocacy is an area that's also near and dear, I know, to Paula's heart and certainly to mine. It's a wonderful program to get people involved, get them engaged, and a great way to battle your dystonia. So the DMRF works with 3 other dystonia patient organizations to form the Dystonia Advocacy Network. We work with the Benign Essential Blepharospasm Research Foundation, the National Spasmodic Torticollis Association, and the National Spasmodic Dysphonia Association in forming the DAN, or the Dystonia Advocacy Network. We come together, pre-COVID, we came together once a year in Washington to meet with members of Congress or their staff to help them understand what dystonia is and how they can help us with this. We had to last year pivot very quickly to have our advocacy day be virtual, and then we repeated it again this year. Although we really focus on at the federal level and our activities around one day of the year, it's really a year-round program because we want to make sure that our legislators know that we're still here, and we have we're asking them for support of important programs throughout the year. So pictured here on the left is Dr. Pedro Gonzalez Allegra and Dr. Cynthia Camella. They have both been recipients of grants through the Department of Defense Peer Review Medical Research Program, and we'll talk a little bit more about that later. And then pictured here on the right, this is Carol Rawson. She is the Vice President of Public Policy for the DMRF, and she's also the chair of the Dystonia Advocacy Network. And she's pictured here with her daughter, Liz. Both Carol and Liz have DYT1 dystonia and have both been very active advocates over the years. This is a picture pre-COVID of some of our advocates who came to Washington one year, the night before they stormed the Hill to talk about dystonia. We work, as I said, collaboratively. And when you're meeting with members of Congress and their staff, they appreciate that as a disease community, we are working collaboratively and speaking with one voice. And because we are working collaboratively, that voice can be louder. And we talk with them about what our needs are. So we always ask for funding for NIH. We want to make sure that when researchers who are getting initial funding from the DMRF and they get that preliminary data and it's very promising, we want to make sure when they take that strong science to NIH that there's funding there for their good science project to be funded. I served on the advisory council for the National Institute of Neurological Disorders and Stroke. I know that there was good science that we were not able to fund because NIH didn't have appropriate funding. So being able to say to your elected officials, we need more funding for research is really important. We also talk about patient access to treatment. We want to make sure that everyone has access to all approved treatments for dystonia. We want to make sure that people have access to the advancements in science. So we talked a little bit earlier about insurance coverage for genetic testing. These are the kinds of things that we will take on to help our legislators understand, and then ultimately insurers, even insurers like the Centers for Medicare and Medicaid Services. We've had meetings with them to discuss why they need to make some changes in providing access to coverage for treatment. If they're not covering treatment, you don't have access to the treatment because treatments are expensive. So we take on those kinds of issues. At the DMRF, we're also willing to and happy to help with insurance appeals. We do this pretty routinely. If people are having trouble with their insurance company, we can add whatever we can to that appeal process. Knowing that you're having trouble with that particular insurance company is helpful to us because we track it so that we're able to say to Senator Blumenthal, did you know in Connecticut, X, Y, and Z insurance company is not covering FDA approved treatments for dystonia, or they're making it difficult for people to get coverage. So that's the kind of information that's really helpful to us in our quest. I talked a little bit earlier about the Department of Defense peer review medical research program. We know that people who have experienced a traumatic brain injury or a traumatic limb injury can develop a subsequent dystonia. And that this is happening to some of our active military if they have had a TBI, a traumatic brain injury. But it doesn't always occur right away. So they're not always making the connection between that injury and their dystonia. So we believe we have a strong case with the Department of Defense to have dystonia listed on this list of eligible conditions for study. It's something we have to do every year. It's renewed every year. It's 24 conditions that are deemed eligible for study. And if we get on the list, then our researchers can compete for these dollars. If we're not on the list, our researchers can't compete for the dollars, and it's a real problem. We've been on the list now for 10 years. And in that time, over $17 million have been awarded in dystonia grants. So it's a really important part of our research funding strategy. But as I said, we have to get on the list every single year, and it's a struggle. We currently have an action alert out now asking people to contact their senators and requesting that dystonia be on the list for the peer review medical research program for the next fiscal year. We alert all of our advocates, people who want to be a part of the advocacy program. We provide training for them. We provide template letters that you can use in these communications. And we provide support for you so that you're not just sort of out there on your own. We want to work with you as you develop your relationships with your elected officials. However, at the end of the day, it is your personal stories that really make a difference. The staffers and members of Congress are truly moved by these stories. And the bill numbers and how much money we want for NIH, we can put that in writing and send it to them in a packet. But I can tell you that if you go back the following year, they will remember your story. And we're grateful to all of our dystonia advocates for their willingness to share their stories. It's no small thing to share the intimacies of your health journey with a stranger. But so many people have been so incredibly generous in doing so that we've been able to make this progress, get this $17 million for dystonia research, get NIH funded, help patients get access. All of that is really done through the sharing of personal stories in our advocacy program. If you're interested, please let us know. You can talk to Paula, you can talk to me, you can email us. We'll be happy to send you the information. Then I want to talk a little bit about just being a part of the dystonia community. Some of you may have attended the Providence Zoo Walk or the Bronx Zoo Walk, depending on what end of Connecticut you live in, north or south. Our zoo walks were really designed as community events to send a strong message to people that they're not alone. Obviously, with COVID, we had to make some changes last year. We held our first virtual Zoo Day on September 12th last year. I'm pleased to say we had representatives from all 50 states. We had representatives from 9 different countries, and 2,500 people joined us that day for this online streaming program. We got to go behind the scenes in some zoos. We got to do some artwork. It was just a day that was full of fun activities. And we have it scheduled this year for September 25th. There's no cost. It's a day for you to put your stake in the ground that you're a part of this community. You want to help us raise awareness, but you also want to support others in the community. So it's just really a wonderful day. And I hope that you'll consider joining us. It's fun. We expect hope this year that people will also be able to get out to zoos and get outside and gather in small numbers, depending on sort of where you are locally. But we're still planning for this virtual Zoo Day on September 25th and hope that you will join us. And with that, I just want to thank you all again for joining us today and for your support of the foundation and the work that we do. We can't do it without you. We can't do it without dedicated physicians like Dr. Machado and dedicated healthcare professionals like Megan Rood. And dedicated board members like Paula Schneider. So we're grateful to all of them and to all of you. So thank you. And I'll turn it back over to Paula.
Yes, I just want to echo Janet's sentiments about being so happy that all of you were able to join us today. And if you need to get a hold of us for anything, feel free, and you can contact the foundation to get my information. I'm sorry, I don't have a screen for that. But please feel free to, again, contact us with anything that you want to participate in or any questions. And thanks for attending today. And I hope to see you at another event. Thanks.
Thank you, everybody. Enjoy the day.